Good afternoon, everyone, and welcome to today's Health Action Council webinar, Pharmacogenomics, Improve Health, Reduce Drug Spend, hosted by Prescription Care Management. My name is Rick Westfall, and I am the Director of Education here at Health Action Council. This afternoon, we're joined by a panel of experts on pharmacogenomics. First, we have Dr. David Merritt, Chief Pharmacist at Prescription Care Management. Dr. Merritt has been instrumental in the development of PCM's Prescription Savings Program, and since 2010 has led extensive research to improve the methodology behind identifying safe, effective therapeutic alternatives to high-cost drugs. His work is continually expanding PCM's proprietary database, which provides the company its ability to help patients identify lower-cost medications, manage medical conditions, and improve their quality of life. Joining Dr. Merritt is Mark Woolery, Chief Operating Officer at Wellvia. Mark oversees all business development and operations efforts for Wellvia, as well as heading up strategic partnerships throughout the company. Bringing more than 15 years of experience in healthcare, he is instrumental in promoting Wellvia's industry-leading telemedicine, behavioral health, EAP, and pharmacogenomics solutions to more than 3 million members. Finally, we have Troy Moore, Chief Scientific Officer at Kailos Genetics. Troy has led the development of targeted next-generation sequencing technologies for clinical applications at Kailos. In 2002, as co-founder of Open Biosystems, he served as Chief Technology Officer, where he was responsible for the development of products in the areas of RNA interference and gene expression analysis. Today, our panel will examine why many people are on the wrong drug or incorrect dose, which leads to lower drug efficacy, increased adverse drug reactions, and overall drug spend. We'll take an in-depth look at pharmacogenomics, also known as PGx, a developing science which investigates how genes interact with certain drugs. PGx is proven to strengthen member health and lower drug spend with innovative testing and technology. The reason is that gene variations can cause drugs to be ineffective as well as adverse reactions. You'll come away with an understanding of the science behind PGx testing, the innovative delivery system that puts members first, and how PGx improves pharmacy benefits while lowering pharmacy costs and reducing medical spend. With that, Dr. Merritt, Mark, Troy, take it away.
So we're going to talk today about pharmacogenomics, right, which is likely a new term and a new set of science for most people on the call. So let's start at the beginning with, what is metabolism, right? Typically, you'll think about metabolism as, she's very skinny because she has a fast metabolism, or he's very heavy because he has a slow metabolism. And really, what you're thinking about is how long does your body take to digest food, extract energy from it, and eliminate it from the body, right? Drug metabolism is very similar. When you take a medication, your body is going to break it down. You'll get some benefit from it. You may have an adverse reaction from it, and then it's going to eliminate it from your body. And when it does so, that whole process is drug metabolism. Okay, next slide. We're talking about this because for most of you, if you were to poll your members, you would find that over half of them have taken a prescription drug in the last 30 days, right? And as they get older, they typically find themselves on more and more medications. It's a term that you'll hear throughout this presentation called polypharmacy, right? Taking multiple medications at a time. And typically those medications are going to be things for pain control, mood-altering antidepressants, control of heart disease by lowering cholesterol, anti-nausea if one's had surgery or an accident, those types of medications, right? And so those are exactly ones that are applicable with pharmacogenomics. Next slide, please. So when a physician goes through their training, they'll go to medical school, do some internships, rotations, and then they'll enter into practice, and over time they see a lot of patients and they develop a repertoire of medications that they use to treat those patients. The problem is about half of those patients are not going to metabolize one or more of those medications, quote, normally, right? And so when they come back in, or you come back in and you talk to your physician, you say, I'm really not getting relief from these headaches, or my back is still hurting, even though I've been taking this for a couple of weeks. What they're going to do is, well, okay, when those don't work, I try this one, right? Let's give this one a shot and see how it works for you, right? That's the trial and error method of prescribing medications, right? Let's just keep trying them until we find one that works for you. Next slide, please. More recently, you may have heard, in the media, something about personalized medicine, right? And that's trying to move away from the trial and error, one-size-fits-all approach to prescribing medications, right? So rather than just saying everybody should get this first medication, and if it doesn't work for some of you, then we'll try the second medication. If that one doesn't work, well, we'll try a third one, right? We'll just keep going until we find one that works for you. We want to take a more personalized approach. Using genetics, sequencing your DNA, looking at changes in that DNA, we're able to categorize people based on changes in their DNA and how they will respond to medications. Okay? That's personalized medicine. Or, next slide, please. Also known as pharmacogenomics, PGx. Okay? That's taking a population of people, sequencing their DNA, and using those changes identified in their DNA. They're not good changes or bad changes, they're just differences, right? And using that information to best prescribe medications so that they get the right drug at the right time at the right dose. Okay? And so if we get that correct, next slide, please. If we get that correct, we're then moving away from this trial and error approach, right? We're using DNA to better prescribe medications. And when we get it correct, we reduce the adverse drug responses. We improve the outcome on the medication. You get more relief. You get the benefit that the physician's trying to get from that medication in treating your symptoms. And when you do that, you find that your overall healthcare spend is pretty dramatically lowered. Right. Next slide. So here we're going to take a quick break, and I would ask that you respond to a poll question. Have you or anyone you know experienced an adverse drug event? Okay, so it looks like over half of you have personally experienced that, and that's not unusual, whether it be yourself or someone that you know, right? We're going to talk about the reasons why that is the case here in the next couple of slides. So being a scientist, I'm pretty skeptical by nature, right? And so if I were you, I'd be sitting there going, well, if pharmacogenetics is so great, why isn't it being utilized everywhere? Why aren't all of our physicians using it to prescribe their medications? Well, I can tell you that there is a long history of your tax dollars going into funding basic and clinical research over the last 50 years to develop a whole knowledge base of pharmacogenetic information. However, when physicians go through training, they don't get a whole lot of experience with genetics. So it being a relatively new field, and that lack of training, there's a reluctance in the past to ordering this type of testing. That's pretty rapidly changing as the benefits are being seen. It becomes more affordable, and the effects are more well documented in the literature. And so we're going to talk about some of those studies today. Next slide, please. In 2016, a rather large study was published of 23,000 patients, randomly selected from the population. They underwent pharmacogenetics testing, and about 17,000 of them, or 75% of them, it was recommended that they have a therapy change. And you can see the top 8 drugs here. They're not anything esoteric, right? These aren't some of the drugs that you hear about on the news, right? Of this particular medication works for this very specific type of disease, right? These are pretty well-known, highly utilized medications, right? So if you're on something like warfarin, a blood thinner, and it's not working for you, clotting is going to result, right? A stroke or a heart attack could result, right? If you're on oxycodone and it's not working for you, you're not getting the pain relief that you want, All right. So let's go to the next slide. This comes about because of changes in DNA, right? And there's a lot of genes that get tested in pharmacogenetics applications, but there's a certain family of genes. They're called cytochrome P450s. It's a mouthful. Usually we talk about them as being CYP genes, CYP genes, CYP genes. And most individuals are not normal metabolizers when it comes to their CYP genes. This is just an example of 3 of those CYP genes, CYP2D6, 2C9, and 2C19. And you can see that a large percentage of the population is not a normal metabolizer associated with each one of those genes. Next slide. That first one, CYP2D6, it alone is responsible for influencing up to 25% of the drug's metabolism. So you think about that, a quarter of all the medications that are prescribed, that one gene, CYP2D6, plays a very influential role in how that drug gets metabolized. When those drugs get metabolized, that can lead to things like, in the case of opioids, painkillers, if you metabolize them too fast, you get a much higher dose in a much shorter time than you're expecting. Those can lead, as you could imagine, to complications. Right? Or you can be too slow of a metabolizer. And when you take those drugs, you don't get any benefit from them. You can't break them down and turn them into their active form. In either one of those cases, that can lead to misuse over time, which we'll speak to again here in a moment, because you're not getting the desired effect, right? Next slide, please. So when patients go into the hospital, they often receive pain control, right? And this was a couple of studies that were done in 2015 and 2017 that showed that when you metabolize too fast or too slow these opioids, and you have that, these are considered adverse reactions, right? You get too much too quickly, can OD, or you don't get any control at all, and it takes them several days to figure out how to control the pain. You end up staying in the hospital longer. That cost of care goes way up every day you spend in the hospital, right? And it's also correlated with about a third of the people end up back in the emergency room within a 30-day period. And additionally, these people are more prone to a long-term abuse of opioids because they have to stay on them for an extended amount of time to get the pain under control. Next slide, please. So a study done in 2017 tried to look at the benefits of this, right? So 50 patients that were scheduled for abdominal surgery underwent PGx testing, and then they used that information to prescribe the pain medication. When they did this, they were able to reduce the overall amount of narcotic usage by 50%. If you can reduce things by 50%, you're also going to be reducing the analgesic-related side effects. And it was very clear that the people had a better experience. Their overall benefit improved, actually, by giving them less of the narcotic. Next slide, please. They did this by prescribing NSAIDs to help with the pain control. Pharmacogenetics can also be used to test things like NSAIDs, which are commonly thought of as things like ibuprofen, Tylenol, acetaminophen, and some other medications. Right? So there are plenty of good alternatives, and pharmacogenetics can help you in selecting the right one and getting the right dose of those NSAIDs as well. Next slide, please. So it also goes beyond pain management, right? So the other thing, when people are undergoing surgery, chemotherapy, traveling, especially by boat or train or some by car, a physician will often prescribe what's called an antiemetic, right? An anti-nausea medication. Zofran's a very common one prescribed. It's relatively inexpensive. It's $40, $45 a tablet. And so you go on your trip or you go through surgery and you take Zofran so that you can control the nausea, because pain and nausea are the two things that we don't want to suffer from, right? 30% of those people will not respond to this medication due to changes in their genes. 30%. So that means you're on that trip, your vacation gets destroyed because you're nauseous the whole time, or you come out of surgery and they can't get your pain under control and they have to put you back under to try to figure out what they can do to manage the pain. Right? Not good alternatives. What is a good alternative is getting pharmacogenetics tested and selecting a different medication before you go into surgery or before you go on that trip. And there are plenty of good alternatives available that are the same or less cost and are going to work for you. Next slide, please. So we've talked sort of globally. Now we're going to switch and talk a little bit about specific people, right? So we've got a series of case studies here. We're going to start with Renata. Renata is a 35-year-old female. She's on oral contraception. She has a pretty high-stress job, travels a lot for work, suffers from heartburn and headaches, right? So her physician has prescribed a proton pump inhibitor to control the heartburn, and whenever she has the headaches, she takes some ibuprofen. She underwent pharmacogenetics testing. She was negative for increased risk of blood clotting, so she can stay on the oral contraceptives, no problem. The proton pump inhibitor, though, she's probably not getting the desired outcome from that. She's probably still suffering from heartburn. And so there are plenty of other alternative proton pump inhibitors that could be prescribed for, Prilosec, for instance, or another one. Ibuprofen probably is not giving her the most relief. Maybe she's getting some, but it could be better. She would benefit from going to, Excedrin or acetaminophen, Tylenol or something. Next slide, please. Ajit's a little bit more complicated case. 40-year-old male suffering from leukemia. His oncologist is getting ready to initiate chemotherapy and had him test it using a pharmacogenetics test. He's going to go on methotrexate as a chemotherapeutic. And it's not unusual when someone goes on chemotherapy to be treated for depression and also for heartburn, acid reflux. That's a side effect of the chemotherapy, so they put him on a proton pump inhibitor. When he was tested, it was determined that he actually needs a higher dose of methotrexate than is normal. He's also, the antidepressants that they were considering, they need to start at a much lower dose. Not good to start at too high of a dose. You won't get the relief that you want. It can also have some detrimental side effects. So they need to start at about half the starting dose that they normally would to get the desired benefit. And the proton pump inhibitor in this case should work for him just fine. Next slide, please. So Elsie is a 22-year-old female trying to get her ADHD under control as she starts into the workplace. She's also on oral contraceptives. Her psychiatrist is considering Adderall and Focalin to treat her ADHD. So he had her pharmacogenetics tested before he made the prescriptions. In this case, she was positive for a change in factor V, which puts her at increased risk of developing blood clots. So her physician would recommend that she go to a non-oral based birth control to reduce that risk, which can be quite painful or deadly. The Adderall should work just fine for it at normal concentrations. And the Focalin, he would benefit from an increased dose, right? So now he knows the range at which he could start to work. And a pharmacogenetics test would also point out to him that combining Adderall and Focalin can cause an increased risk when you use those together of serotonin syndrome, a particularly nasty disease, although rare, leads to an increased body temperature, muscle breakdown, and possible seizures, right? So these are things that you want to know before you start on these medications. Next slide, please. And then the last case study is, we get questioned a lot about, well, these are all adults, right? Should children get genetically tested? And generally the answer is no. Unless they're suffering from a particular ailment, right, you wouldn't get them genetically tested. However, pharmacogenetics is the exception to that rule. This is information you want to have before you need it, right? And as Brandon points out here, it's not unusual for a young child to end up in the emergency room once or a few times as they're growing up, right, with a broken bone, a cut, a burn, a bump. And usually one of the things they'll do is try to mitigate that child's pain, right? And so Tylenol 3, which contains codeine, is pretty typically prescribed. And in the case of Brandon, he's a very high metabolizer for CYP2D6. Remember that gene that we talked about that is associated with about a quarter of all medications? Codeine's one of those. And because of that high rate, he's going to break down that codeine at a very fast pace. And when he does, it's going to hit his bloodstream very quickly, and he could have effectively OD on the normal prescription level. There've been several cases reported of those, right? And so what you'd really like to know is that information. They could start by giving him morphine, which he would respond to very normally. or they could switch to an NSAID, stronger acetaminophen or ibuprofen, right, to control the pain. Plenty of good alternatives and information, again, that you want to know before finding yourself in the emergency room. So now I'm going to turn it over to Mark Woolery from Wellvia, who will now talk about the implementation options for pharmacogenetics.
Thank you, Troy. It's good to have a scientist partnered on our webinar today, isn't it, to communicate how we can utilize the human genome as a proven tool for personalized medicine. What I'd like to do now is walk you through how you can bring pharmacogenomics to life within your benefits offering. Our goals are aligned with yours, and those are to ensure your employees are healthier and happier while lowering the prescription costs within your health plan. With that being said, I'd like to share with you the two models which we built from our employer group benefit managers requirements, a clinic model and a population health model. So for those of you that may have an on-site clinic in your employer group, we have a model built specifically for you to where obviously it's very easy and accessible for your employees to go to the clinic and have their test completed. That's obviously physician directed. That can be your physician if you have one on site, or in our case, done virtually. We've got a doctor network of a little over 8,000 doctors and can do that in a virtual environment. Some of the benefits of the on-site clinic model, like the telemedicine model, is that there's a high quality lab. You just got done hearing from Troy. That information is very complicated, as I'm sure you're learning. In fact, some would say it's so complicated we had to do it twice today. But Kylos provides great insight into the quality and the drug interactions in which and how our body metabolizes that. There's a pre and post consultation that takes place. So there's a pre-consultation that takes place with the doctor to walk the member through the engagement screening process, if you will, and asking some questions to get some information down, which will become pertinent in a couple of slides from now. And then a post-consultation to ensure that the employee understands his or her medical action plan associated with taking the test. In the true virtual model, it's employer-directed, so if you don't have a clinic on site, test kits are mailed directly to the participant's home. We have seen in the past year and some change that we've been conducting tests with our client base that the participation inside of that model is a little bit higher just because of the sensitivity of sharing DNA and members being able to do that in the privacy and the comforts of their own home. As far as the consultation goes with the doctor, it's exactly the same, but rather it being face-to-face, it's done virtually, both pre and post, same as I described before. Very high member engagement, like I mentioned earlier, and a very high prescription conversion. So not only is there an understanding of how my body metabolizes the medicines that I'm on, but as Troy alluded to, sometimes changes are necessary, whether it's a drug change or a dosage change. And the key, especially for ROI for employer groups, is to make sure that that conversion is accurate and timely. Next slide, please. So the process is a pretty simple 6-step process. First and foremost, there's an analysis done of the population to best determine the number of members that would benefit the most from going through that process. Then you have a pre-consultation, which I talked about earlier, with either virtually or face-to-face, given your situation. We use a common buccal swab, so it's an oral swab where you swab both sides of the cheek to gather the sample. That sample is then returned to the lab, and the lab conducts the proper testing to generate a report that then is given both to the prescribing doctor as well as to the member. That member can certainly take that report to their primary care physician or share it with, quite frankly, whomever they choose to share it with, but is done so in a very safe and secure format. And I'll speak to how they can pull that up here momentarily. And then lastly, a follow-up consultation. So once the report's been generated, and it's customized, obviously, for that particular member's DNA, then a follow-up consultation is conducted so that that member understands all of the information inside of that report. So as far as some member engagement tools, utilizing our system, you're able to go in and track where in the process a member is in the testing procedure. So whether a test has been ordered, whether it's been shipped, returned to the lab, test results are available, and then a follow-up consultation is either been scheduled or conducted. All of that information is done in real time and can be viewed inside of a member's portal, either over the web or on either our mobile app, which is both supported in Apple and Android platforms. Next slide, please. So this is just a sample cover page of a report. A couple of key points there. The reports, I'm not sure how many of the folks out there have seen a PGX report, but most of them are quite lengthy, numerous pages, lots of information. But some of the highlights are really making sure that you gather current medication summary, as well as the gene summary to ensure and to take a look at what drug-to-drug interactions take place. So I've got to understand the drugs that I'm currently on, the drugs that could be prescribed to me in the future, and the interaction associated with doing that. The first few pages of the report are a Cliff Notes version, if you will, that is very comprehensive and a quick summary, but we get down to the nth degree in the report itself. So with that, now that we've heard the science of pharmacogenomics and the options for delivery, we've incorporated a science-based identification tool to get the right members into a PGX program. So like Troy alluded to earlier, they get the right drug at the right time at the right dose. So with that, I'll turn it over to Dr. David Merritt with PCM, and he'll walk us through the front-end identification components of this PGX solution.
Great. Mark, thank you. Appreciate that. The first thing we like to do is, next slide, please. We like to identify our candidates that will benefit from PGX testing. We look at several different things. We look at medications that have a FDA black box warning. This warning appears on certain medications to warn the consumer and the healthcare professionals about safety concerns such as adverse effects and life-threatening risks. A good example of this drug is Plavix, which is a blood thinner that helps reduce heart attacks and strokes. And Troy has talked about metabolizers. If you're a poor metabolizer of this drug, you won't get enough of the active ingredient in your system, thus not getting the blood thinning effect and having a recurrence of the heart attack or stroke. On the other hand, if you're a rapid metabolizer, the medication goes through your system too fast, and it can cause bleeding, bruising, and headaches. So we want to make sure that we can identify these medications and try to avoid them in patients. We also have another issue with, as we talked about earlier, is the older you get, the more medications you take. And we have a term called polypharmacy, where we take more than one medication to treat multiple disease states. A good example of that would be like a diabetic patient. A diabetic takes 1 to 3 diabetes medications. They have poor circulation, so they'll take 1 to 2 cardiovascular medications to improve circulation. They also can experience pain, called peripheral neuropathy, and that's also partly due to poor circulation. They also have other metabolic issues. They'll usually have high cholesterol, so you need to put them on a cholesterol medication. And they can experience acid reflux. And then also, being on all these medications, sometimes the patient can get depressed just with the disease state itself. So it's really easy to see how polypharmacy can occur by constantly adding different medications. We also look at therapeutic classes. Diabetes, cardiovascular, mental health are just a few. On the next slide, we'll see more of those. And we want to incorporate PGX. So we want to make sure that we will do a prior authorization, make sure that the patient qualifies for this. Patients react differently to anesthesia, and so we want to maybe try to do a test before surgery to see how they will react to anesthesia, and also for post-op pain to decrease recovery times. As we age, we take more medications and the body changes. So we want to adjust medications on the amount of medication a patient may be taking or the number of medications they take. We also talk about polytherapy. Polytherapy is a term that uses that they'll use more than one drug to treat one disease state. And a good example of this is hypertension. There are many medications out there for hypertension, such as beta blockers, calcium channel blockers, ACE inhibitors, and thiazide diuretics. These medications all work from different mechanisms, but all lower blood pressure. So some of these medications you may not need that could be redundant, and so we can maybe decrease half of the medications and still get the same blood pressure lowering effect. And then we also want to address the multiple disease states. Again, we talked about diabetes, which has cardiovascular issues, peripheral hyperlipidemia. So these are some of the things that we look at to incorporate PGX testing. Next slide, please. So, back one slide. So looking at some of the therapeutic classes, I said there's a list of disease states that are currently being reviewed during the PGX testing. And as Troy talked about, the science of PGX is growing and it's just blossoming. So as they find more genes to look at, this list will grow. But currently, here are some of the more common ones that are looked at: cardiovascular medications such as antiarrhythmics. They also look at mental health medications, antidepressants, pain, oncology, and so on. But like I said, this list will grow as the science progresses. Next slide, please. Here we have an interactive poll question. Have you or a loved one ever taken a medication in one of the most commonly tested categories? As you can see from the poll question, almost everybody has experienced it or has a loved one where they experienced a reaction and have one of these disease states. Next slide. Okay, so we want to look at the health benefits for the members. Adverse drug events are very common with medications. The United States has over 2.2 million adverse drug events annually in the United States. Adverse drug events account for over 700,000 emergency room visits annually in the United States. Of these, 120,000 of these require further hospitalizations. With the current opiate crisis in the United States, testing can decrease the potential for addiction. So giving a patient the right medication at the right dose for the least amount of time can help decrease the chances of addiction. Also, this will apply for post-op anti-nausea medications. This will also help decrease recovery time. If we can get the right medication and the right dose to the patient, we can decrease the trial and error prescribing by physicians. This in turn will decrease adverse effects, decrease doctor's visits, decrease hospitalizations. PGX allows the physician to do more precise prescribing. If we can decrease the number of medications, we can also decrease the number of side effects. 53% of the patients on polypharmacy were on the wrong drug and or at the wrong dose. This can cause an employer up to $600 or more per member per year. And with PGX testing, we can find that we can save lives. Last year, over 100,000 deaths occurred because of adverse drug reactions. Adverse drug interactions is the 5th leading cause of death in the United States. So we can see the value of PGX testing. Next slide, please. Okay, benefits for the group. If we can manage chronic health conditions through PGX testing, we can improve the quality of health and the productivity of your employees. As you can see from the slide, depression is one of the leading causes of employee absenteeism. After being evaluated through PGX testing, an employee can receive the right medication at the right dose to improve their health and decrease absenteeism. And the slide shows the cost to an employer and how much absentee costs. For an hourly employee, it's over $3,600 a year. For a salaried one, $2,600 a year. You have a company of 1,000 to 2,000 people, a small company, you can see how much this is going to affect your bottom line. Next slide, please. Okay, benefits to the group. We want to look at, again, we want to look at decreasing adverse drug events. They say adverse drug events attributes $3.5 billion of extra medical costs annually. If we can get the patient on the right medication, we can decrease office visits, hospitalizations, and drastically decrease the overspend of money. If we can look at also post-surgery readmissions, the average hospitalization stay is anywhere from $10,000 to $15,000. If we can do testing to find out the right medications for the patient post-operatively, we'll be able to decrease readmissions drastically. Again, the goal is to eliminate adverse drug events. As we stated earlier, PGX testing helps get the right medication to the right amount. I said in turn, this will decrease pharmacy and medical expenses. The goal with PGX testing, we want to see fewer medications dispensed. Decreasing the number of medications the patient's taking will also increase compliance with the patient, improve their health, thus decreasing pharmacy spend by the employer and the employee. Next slide, please. So we kind of want to summarize the benefits of PGX. So we have some bullet points on there, and we just want to reiterate that PGX testing helps physicians prescribe the most effective medication to reduce adverse drug events, which will improve the quality of life of the patient. Giving more information to the physician enables the right medication at the right dose for the right disease state. And the bottom line is you want to get the right medication to your employee. This will improve the employee's life in and outside the office. It will create a more productive and valuable employee for your company. By getting the right medications to your employee, employers will see a decrease in office visits, decrease in hospitalizations, and decrease in prescription spends, and overall decrease in medical expenditures. Next slide, please. So getting started, Mark alluded to the models that we offer. We have an on-site clinic. A lot of companies have on-site clinics. If you don't, we also have the telemed, and I won't go into a lot of detail of that. He kind of already went over the models for you. You want to get the correct implementation into your language of your benefit plan so that the employee knows what the employer is offering. And then the biggest thing is you want to identify the right candidates. And we look at all the data, and from the information that we shared with you, we look at multiple disease states and multiple medications to help get the right candidates for the test. To sum up everything in the webinar, so the implementation of PGX testing to your company plan benefit will decrease adverse drug events, improve the quality of health of your employees, and in turn will decrease pharmacy and medical expenses to employees and employers. We would like to thank you for taking the time today to learn more about PGX testing and the value it brings for members and employer groups. If you have any questions after the webinar or questions about prescription care management, please contact Linda. Her information is on the screen as we speak. Rick would also be able to give you contact information as well. Rick would be happy to take any questions at this time from the audience.
Okay, so, listening to your presentation today, and I appreciate it even more hearing the first portion of it twice, it seems like this is the next logical step in accurate drug prescriptions, whereas our docs and physicians are informed by medical school, by their residencies, and by journals. It seems like that 10 years from now, this will be the norm. Would you say that's an accurate forecast for the future?
I can take that. Yeah, that's what they're looking at. They're actually building tools in the EMRs, electronic medical records, to actually document these tests. And it's getting more and more accepted. They're actually training people more. They're training doctors. They're training pharmacists actually to help the doctors deliver this. It is a growing field, and it'll grow rapidly in the next 10 years.
To that piggyback, so for those without on-site clinics that go down the telemedicine option, unless it was just over my head, how from that point on, how is that information communicated to an individual employee's primary care doc or their prescribing physician? How is that information transferred from that point?
Yeah, so this is Mark with Wellvia. So through our platform and our delivery method and the way that we've engaged with our client base over the past year, a member has an account on our portal where that information is stored securely. It lives there with them forever, and then they can share that with their primary care physician or a surgeon if they're going in for surgery, whatever it may be. They have the ability to do that in real time and either print it off and give it to them or email it over. It's completely up to them.
And our physicians that are not maybe familiar with this process as the three of you are, is there any pushback from them, or has any disagreement? Have you had anything like that reported, or do they just follow the science and they react accordingly?
Yeah, this is Troy. Typically, we hear from physicians, a lot of interest. There's generally quite a bit of support for it. A lot of times they just don't have the background and the training necessary to interpret all the results, and that's where groups that are trained in it or can review the report and ask questions can really benefit.
Another question from the audience is this data extracted from a full genetic test, or is a specific test done that checks these specific genes?
Yeah, so typically with the pharmacogenetics test, you'll look at quite a few different genes, dozens of genes at a time. You'll also look at very specific changes within those genes. So it's not necessary to sequence a person's entire genome, but it is necessary to sequence some very specific regions of particular genes.
So when you're dealing with sensitive information like genetic code, and it's a topic of discussion we've had here at Health Action Council several times, I see all of the benefit in sharing personal information about myself. It helps shopping, it helps inform decisions, it allows algorithms to target me to try to figure out what I want, and I'm happy with it. I'm happy with it all. But many people are really hesitant to share any more personal information, especially health information, than they have to. Are there, materials, or do you have, a line of attack to assuage kind of these privacy concerns that employees may have when they before they would take their genetic test?
Yeah, this is Mark again with WellVia. I'll take a swing at that one. Of course, first and foremost, everything that we do is HIPAA compliant, and we've got security for days around storing that information and communicating that information. At the same time, we're not a reference lab or have any affiliation or associations with reference labs or affiliations or associations with any kind of pharmacies to where that information is sold or shared, like some people, read about or hear about with some of the other associations with pharmaceutical companies that may be out there.
Okay. Well, it looks like, I have one more question. Can pharmacists in Ohio request the tests? Is from our audience.
Yes, that would not be a problem. Pharmacogenetics is accessible by physicians in every state in the country.
And again, utilizing our platform, if that ever came to fruition, we're a national company and have doctors in all 50 states and serve members in all 50 states each and every day. So not a problem on our end either.
All right. Well, gentlemen, thank you so much for presenting today. Again, I'd like to apologize to my entire audience for our technical difficulties at the onset. I would especially like to thank Linda Brokowski, who I have been in contact with since April, to try to bring this webinar and bring this information out to our membership. As I see it, this is the future in pharmacy. So I want to remind everybody that all the members of Health Action Council that you'll be able to find a copy of the slides and a sewed-up recording in our member center by tomorrow. If you have any additional questions for either myself or for Linda, please feel free to reach out to me at rwestfall@healthactioncouncil.org. I'm now going to launch the continuing education credits for those who are interested. Again, SHRM has been approved. HRCI is still pending. And as soon as that gets through, I'll make sure to get it out to all of you. And of course, before I let you guys go, our annual symposium is coming up next Thursday at the Nationwide Convention Center in Columbus, Ohio. Very exciting. And then our national conference and expo occurs here in Cleveland on February 12th and 13th. So thank you again. Thank you to the panel of speakers. Thanks for bringing this very new information to our membership, and we'll see you next time. Have a great day, everybody.